Okay, now we're going to talk about personality disorders, and that can be found in your book on chapter 31, um, starting on page 654. So, what you will see here, we're going to talk about personality disorder in three clusters clusters A, B, and C. So, we're first going to start off by talking about personality traits, and these can be defined as characteristics in which the individual is born or develops early in life. Okay, personality disorders occur when there are traits. Um, Deviate from the expectations and the individual's culture. They may become rigid and inflexible, and they can contribute to maladaptive patterns of behavior or impairment in functioning, which can lead to distress. All of this is coming from page 655 in your book. The most common symptoms occurring in personality disorder are impairments in interpersonal relationship functions, dysfunctions in cognition, affect, and impulse control. Personality development occurs in response to a number of biological, psychological influences. These variables include, but are not limited to, hereditary, temperament, experimental learning, and social interactions. And we're going to talk about those a little bit more in depth. On the bottom of page 655, you will see a comparison of personality developments, and they're comparing Sullivan, Erickson, and Mailer. Everyone should be familiar with Erickson's, I know, because you all are familiar with that one with your care plan. So I'm just going to ask you to review over that, and we're going to jump straight into personalities. Again, we're going to cover it in three clusters on page 657. Cluster A is going to be behaviors that are described as odd or eccentric. And we have three that falls under cluster A: paranoid personality disorder, schizoid personality disorder, and schizotypical personality disorder. Cluster B is going to be behaviors that are described as dramatic, emotional, and erratic. And we have four: antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. In cluster C, we have behaviors that are described as anxious or fearful. We have avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. I always like teaching this lecture because students oftentimes in the class say, "Oh, I know someone who fits that description." Or oftentimes they may start to compare themselves to the description. So let's get started with cluster A, which is the odd eccentric cluster. And we're going to start with paranoid personality disorder. It is described as a pattern of pervasive mistrust and suspiciousness of others and the misinterpretation of others. This individual may have motives. The clinical picture presents as they're going to be guarded, hypervigilant, and they're going to be ready, or they may have a real or an imagined threat. This individual avoids interactions with other people lest they are forced to relinquish some of their power. They always feel that others plan to take advantage of them, and their perceived slight, injurious insults become long held grudges. They're overly sensitive and they tend to misinterpret even the minute cues within the environment. Because they trust no one, they are constantly testing the honesty of others. These individuals do not accept responsibility for their behaviors and feelings, and they project their responsibility on the others. Predisposing factors to this disorder includes the paranoid personality disorder among relatives or individuals with schizophrenia. They may have experienced some childhood trauma, including neglect. They often learn to perceive the world as harsh and unkind and place a calling for protective vigilance and mistrust. They develop a chip on the shoulder attitude and were met with many rebuffs and rejections from others. Let's take a look at the schizoid personality disorder. This individual is primarily characterized by the ability to form personal relationships. They're seen by others as eccentric, isolated, or lonely. These individuals display a lifelong pattern of social withdrawal and discomfort with human interaction is very apparent. These individuals may go undiagnosed unless it's recognized by an individual seeking health care for other reasons. Many people with this disorder are never observed in the clinical setting. Well, let's take a look at the clinical picture. They often appear cold, aloof, and indifferent to others. They primarily involve themselves in solitary activities, are engaging with animals more than people. They prefer to work in isolation or unsociable, with little need or desire for emotional ties. They are able to invest enormous effective energy into intellectual pursuits. In the presence of others, they appear to be shy, anxious, and uneasy, and they are inappropriately serious about everything, and they have difficulty acting in a lighthearted manner. Predisposing factors include the childhood of this individual often is characterized as bleak, cold, and lacking empathy and nourishing. A child brought up with this type of parenting may develop schizoid personality traits if the child possesses a temperamental disposition that is shy, anxious, and introverted. Let's look at the schizotypical personality. It was once described as the latent schizophrenics. Their behavior is odd and eccentric, but does not decompensate to the level of schizophrenia. Their symptoms are closer to those of schizophrenia than those in the schizoid personality, such as showing significant peculiarities in thinking, behavior, as well as in appearance. Let's look at the clinical picture. They're often aloof and isolated, and they behave in a bland and apathetic manner. They have magical thinking, ideals of reference, illusions, depersonalizations are part of their everyday world. Examples include superstitious, beliefs in clairvoyance, telepathy, and a sixth sense, and beliefs that others can feel their feelings. Sometimes their speech is bizarre. This disorder often cannot orient their thoughts logically, and they become lost in their own personal irrelevance. Under stress, these individuals may decompensate and demonstrate psychotic symptoms such as delusional thinking, hallucinations, bizarre behaviors, but these are usually brief in duration. Predisposing factors include it's common among first degree biological relatives of people with schizophrenia than among the general population. Their interpersonal relationships may provoke other children to avoid relationships with them, or worse, these individuals will engage in bullying, which reinforces their withdrawal from others. Let's move on to the cluster B personality disorders. The first one we're going to look at is the antisocial personality disorder, and they're irresponsible, exploitative, and guiltless behaviors that reflects the general disregard for the rights of others. They're exploitant and they manipulate others for personal gain and unconcerned with obeying the law. They have difficulty sustaining consistent employment and developing stable relationships. They are found more frequently in those in lower socioeconomic classes, especially highly mobile inhabitants of impoverished urban areas. Let's look at the borderline personality disorder. This one is seen commonly in the psych facility. They have a pattern of intense and chaotic relationships with affective instability and fluctuating attitudes towards other people. Oftentimes, they've had severe job losses, interruptions in their education, marriage, as well as breakups. It's estimated that this is more common in women than in men. The care plan for this patient can be found later in this chapter under bipolar disorder. So I also want to mention with this borderline personality disorder, these individuals are impulsive. They are directly and indirectly self-destructive, and they lack a clear sense of identity. Let's look at the histrionic personality disorder. They are characterized by colorful, dramatic, extroverted behaviors, excitable, emotional people. They engage in seductive, flirtatious behaviors to reassure themselves that their attractiveness and it will gain approval. The clinical picture, they're self-dramatizing, attention-seeking, overly gregarious and seductive. They use manipulative and exhibitionist behaviors in their demand to be the center of attention. To an extreme, what our society tends to foster and admire in its members to be well liked, they like to be successful, popular, extroverted, attractive, and sociable. They tend to use their physical appearance as a means to draw attention to themselves. They have a driven quality and all consuming need for approval, and they are desperate, striving to be conspicuous and evoke affection and attract attention at all costs. They are highly distractible and flighty by nature. They have difficulty paying attention to detail. They can portray themselves as carefree, sophisticated, and on the other hand, they exhibit a naive to being naive on the other hand. They are strongly dependent. Interpersonal relationships are fleeting and superficial. Interactions with others tend to be provocative and sexually inappropriate. This person with histrionic personality disorder, having failed throughout life, develops the richness of inner feelings and without resources from which to draw. They lack the ability to provide another with genuinely sustained affection. The predisposing factors, hereditary may be a factor among first degree biological relatives with people of the disorder in the general population. Some of the traits may be inherited, and they have a genetic predisposition in their childhood experiences. Well, I'm sure we all know someone in this next category, narcissistic personality disorder. They have an exaggerated sense of self-worth. They lack empathy and are hypersensitive to the evaluation of others. They believe that they have an inalienable right to receive special considerations and that their desire is sufficient justification for possessing whatever it is they seek. The clinical picture, they lack humility. They may be self-centered and exploit others to fulfill their own desires. They often do not perceive their behavior as being inappropriate because they view themselves as superior, being that they believe they are entitled to special rights and special privileges. Although often grounded in a grandiose distortion of reality, their moods are usually optimistic, relaxed, cheerful, and carefree. Their mood can easily change, however, and they can become of fragile self esteem. In selecting a mate, the narcissistic individual frequently chooses a person who will provide them with the praise and the positive feedback that they require, and who will not make much from their partner in return. Who will not ask much from their partner in return. So let's look at the predisposing factors. A parent-child dynamic of either excessive parenting or excessive criticism. Children whose parents have this disorder, the children may develop into adults with narcissistic personality throughout modeling the parents' behaviors. Narcissism may also develop from an environment in which the parents attempt to live their lives voraciously through their child. Do you know any parents who attempt to live their life through the child? Research has identified a decreased volume of gray matter in the area of the brain responsible for empathy, emotional regulation, compassion, and cognitive functioning. Last but not least, let's talk about cluster C, starting with the avoidant personality. It is extremely sensitive to rejection and thus may lead to very social withdrawn life. The extreme shyness or fear of rejection. Let's look at the clinical picture. They're awkward and uncomfortable in social situations. They're timid, withdrawn, or perhaps they may be cold or strange. These individuals have touchiness, evasiveness, and mistrustful qualities. Their speech is usually slow and constrained with frequent hesitations, fragmentary thought sequences, and occasional confusion and irrelevant digressions. They view others as critical, betraying, and humiliating because of their fear of being rejected. They often have depression, anxiety, and anger at oneself for failing to develop social relations and commonly experienced. So, predisposing factors, the avoidant personality, contributing factors are most likely a combination of biological, genetic, and psychosocial influences. Some infants who exhibit these traits are hyperirritability, crankiness, tension, withdrawal behaviors are often seen. Let's look at dependent personality. It's characterized by the lack of self-confidence and extreme resilience on others to take responsibility for them. Sometimes they're a point of intense discomfort with being alone or for even brief periods. These individuals with this disorder tend to allow others to make decisions, feel helpless when alone, and they act submissively, subordinate needs to others, tolerate mistreatment by others, demean oneself or gain acceptance, and fail to function adequately in situations that require assertive or dominant behaviors. A clinical picture, they have a notable lack of self-confidence that is often apparent in their posture, their voice, as well as their mannerisms. They see the world through a rose-colored glass, but when alone they may feel pessimistic, discouraged, and dejected. They are willing to let others make their important decisions. Should a dependent relationship end, they feel fearful and vulnerable because they lack the self-confidence in their ability to care for themselves. Predisposing factors include a dependent temperament. So they're very dependent. The infant becomes attached to one source of exclusion of all others. A problem may arise when parents become overprotective and discourage independent behaviors on the part of the child. Our next one, and it's our last one, is the obsessive compulsive personality disorder. They tend to have serious and formal demeanors and have difficulty expressing emotions. They are overly disciplined, perfectionist, and preoccupied with rules. They are inflexible about the way in which things must be done to have a devotion to productivity and exclusion of personal pleasure. An intense fear of making mistakes leads to difficulty with decision making. When we look at a clinical picture, individuals with obsessive compulsive personalities are inflexible and they lack spontaneity. They are meticulous and they work diligently and patiently at tasks that requires accuracy as well as discipline. Social behaviors tend to be polite and formal. They are very rank conscious and characteristics that is reflected in their contrasting behaviors with superiors as opposed to inferiors. People of the obsessive compulsive personality disorder, they have a bureaucratic personality. They see themselves as conscientious, loyal, dependable, and reasonable, and are contemplous of people whose behaviors they consider frivolous and impulsive. Again, these individuals are have a great deal of ambivalence, conflict, and hostility. So, the borderline personality disorder is mentioned here in your book, and it falls under the cluster B. The borderline personality disorder is on page 663, and this individual borderline was introduced to the clients who seem to fall on the border between two categories. Other terms have identified them as the ambulatory schizophrenic, pseudoneurotic schizophrenic, and emotional unstable personality. When the term borderline was first introduced or first proposed in the third edition of the DSM 5, the psychiatrist feared it might be used as a wastebasket. So, individuals with borderline personality, the clinical picture is seen as a state of crisis, and they have frequent mood swings, although there may also be comorbid bipolar disorder. Their effects is one that is extreme intensity, and they have behaviors that reflect frequent changeability within days, hours, or even minutes. They are sometimes described as thriving on chaos because of they frequently generate chaos. Oftentimes, these individuals exhibit a single dominant affective tone, such as depression, which may give way to an anxious agitation or inappropriate outburst of anger. So, later on, we're going to cover chronic depression, bipolar disorder, inability to be alone. I'm going to just review these briefly with you because it's very important. Chronic depression on page 664. Also, you see the diagnostic criteria for borderline personality disorder. So, chronic depression, it may be rooted from feelings of abandonment by the mother in early childhood. Underlying the depression is a sense of rage that is sporadically turned inward on oneself, externally on the environment. Bipolar disorder, much has been written about bipolar disorder. These common features have led to suggest that bipolar disorder should be considered a disorder along the bipolar spectrum. So, these individuals have affective instability in which moods shift from depression to irritability or anxiety, and some common bipolar depression. Inability to be alone. Because of their chronic fear of abandonment, clients with bipolar depression have little tolerance for being alone. They prefer frantic search for companionship, no matter how unsatisfactory, to sitting with feelings of loneliness, emptiness, and boredom. Clinging and distancing. The client with bipolar disorder exhibits patterns of interactions with other characterized by clinging and distancing behaviors. When clients are clinging to another individual, they may exhibit helplessness, dependent, and even childlike behaviors. They want to spend all their time with the person to express a frequent need to talk and often seek constant reassurance from him or her. Impulsive behaviors, even self mutilization, may result when they cannot be with the chosen individual. Splitting. Splitting is a ego defense mechanism that's often seen with bipolar disorder. In their view, it including themselves, a life situations are either all good or all bad. For example, your book mentions a nurse-patient relationship may be perceived as intense or overwhelmed. No one in the world could help me the way you do. This perception persists. This perception persists until the individual with bipolar disorder feels threatened in some way, which could be as simple as the nurse looking at the person with a different expression or not being immediately available to spend time with the person. Because this individual struggles with emotional regulation, suddenly the nurse is devalued. Valuing is shift to another nurse at that point. The image of the former nurse will change from being the benefit caregiver to the hateful and cruel persecutor. Manipulation. In their effort to prevent the separation they desperately fear, clients with this disorder become adept at manipulation. Virtually any behavior that's acceptable means of achieving a desired result. It relieves the separation anxiety. Playing one individual against another is a common ploy to ally these fears of abandonment. So you may see manipulation being done by some of these patients. In addition, you may see self-destructive behaviors. Repetitive self-mutilating behaviors can be seen with individuals with bipolar disorder. Oftentimes, safety is the huge concern. It's a primary concern of ours. They may engage in things like swallowing pills in an area where the person will be discovered by others, or swallowing pills and making a phone call to report the deed to someone. Other types of destructive behaviors include cutting, scratching, as well as burning. Um, Various theories have been suggested about the way these individuals can inflict pain on themselves. Impulsivity. Individuals with bipolar disorder have poor impulse control. Impulsive behaviors are associated with bipolar disorder, and they include substance abuse, gambling, promiscuity, reckless driving, binging, and purging. Often these behaviors occur in response to real or perceived feelings of abandonment. So this will conclude our lecture on personality disorders. I do want you to review page 667 that goes over borderline personality disorders. I want you to review the care plan on 668, as well as the goals and interventions. In addition, you have a concept map on page 672 with the borderline personality disorder. I like the concept maps. You have a table on page 675 that goes over the antisocial personality disorder as well as the care plan. You have a concept map that goes over the antisocial personality disorder on 678. And you have the case studies, summary key points, review questions, and clinical judgment. Again, all of this is going to be very helpful as you review and prepare for your lecture. So, safety will be a concern with all of these personality disorders, all right? So, you always want to think safety. Again, you have those actions, and that's where the nurse takes action And all of these are outlined in your care plan. So be sure to read over those and be familiar with the medications that go along with each of these as well.